Yeah, thank you, sir. Uh, Good afternoon and welcome everyone. Thank you for joining us for today's webinar. My name is Dr. Amit Borse and I am a Senior Product Manager with IVA, a division of MCure Pharmaceuticals Limited, a pioneer in the field of gynecology and IVF. We at MCure are on a mission to nurture and support 28 days with programming 28, which is based on the concept of ovarian and uterine cycle and managing the same with exogenously given GnRH analogs, gonadotropins, and hormones as per different protocols. MCure promises to deliver all possible support in terms of therapeutic agents and academic support like this. Under academic support, we have this program, #Programming 28 webinar series, and this is an initiative towards continuing academics in this time of lockdown due to outbreak of COVID. We are fortunate enough to have with us very eminent and renowned speakers today to guide us on the topic male infertility. Today's moderator is Dr. Sunil Jindal sir, and I would like to introduce him for you. Dr. Sunil Jindal sir is an andrologist and reproductive medicine specialist for Jindal Hospital, Meerut. Sir has many national and international publications to his credit. His passion is andrology and he has contributed immensely to this topic, patients, and guided many professionals on this. May I now request Sunil Jindal sir to take over the session and share your slides. Sir, can you hear me?
Yes, now I can hear you, and thank you very much. Thank you very much for your kind introduction. And we are very lucky today to have such an august gathering with us of phenomenal panelists who would be able to add a lot to all of our knowledge. And we had planned with MCure, and in fact, ISAR had planned to have a particular program in which we could have a case scenarios where every case would be an answer to 4 or 5 of your questions. So they're all true case scenarios, the way cases have been, and we would be discussing true cases with you. And these cases we'll bring forth to you. And let me be honest with you, earlier we would have met in conferences, but today we meet on the web, and in fact, any number of people can meet on the web, but some things which I always misses, एक शेर में आपसे कहूँगा कि अजीब कर दिए रिश्ते इन हालातों ने, अजीब कर दिए रिश्ते इन हालातों ने, फुर्सत सबको है पर मुलाकात किसी से नहीं. और एक और बड़ी सुंदर चीज आपसे कहूँगा, बहुत गैरों से मिले तो फूल गए हम, आई खुद से मिलने की बारी तो ऊब गए हम. तो कहानी सच ये है कि I'm going to start now the program. I'd like to introduce to you all the eminent speakers which we have, and we have some amazing speakers with us. This of course is yours truly, whose introduction has been very kindly given by Amit Borse. I have 3 children, an amazing wife. I'm a surgeon and urologist by training, an ART specialist and andrologist by passion. I've given birth to so many children, about more than 5,000, and honestly wish this world everybody had a child. We have Dr. Marlon Martis from Philippines. He is somebody who's joined us from Philippines. He is a urologist, and he has received training at 3 of the best places in the world. Cleveland Clinic. He has also received training in Miami, Ohio, and he has received training in the Mecca, the Weill Cornell University. So he's one man with us who has received training in all the top places in the world and is joining us from Philippines. Welcome, Dr. Marlon.
Yes.
Good morning.
Good morning, sir. Thank you for the invitation. Thank you so much.
We have Dr. RahulReddy with us. All of us know him. He's a very famous andrologist from Hyderabad and is the director of Androcare Andrology Institute. Apart from the fact that he has many awards, one thing which is very pertinent with him is that he is an amazingly practical andrologist We are very lucky to have you with us. Rahul, your patients, I believe, have a 4-month appointment. So we're lucky to have you right away.
Nothing like that, sir. Thank you very much.
We have Dr. Sudesh Kamath. Who does not know him? He was in the team of the people who gave birth to the first ICSI in India. He has over 300,000 oocyte cycles till date, has injected oocytes, which means it must have been about, from what I gather, about 70,000 cycles he must have done, which is phenomenal. And apart from that, he's given birth to babies in Nepal, in Rwanda, Africa, and a lot of other countries. People dream of giving birth to babies in different countries. He actually has made it possible in thousands of babies. Welcome, Dr. Kamath, with us.
Thank you, sir, for the wonderful introduction. It's always a pleasure to be on your panel.
Such a pleasure, sir. Dr. Ekika Singh, she is from Mau. She's a very highly qualified gynecologist who has a lot of interest in male infertility. So we thought, why not Dr. Ekika Singh be with us from the perspective of a gynecologist? Because a lot of people who would be joining us are going to be gynecologists, would really be having questions to ask us. And those questions would be beautifully answered by Dr. Ekika Singh. We have Dr. Sulva Arora, who is from the Nova IVF Mumbai. She is phenomenally gifted, having written a lot of textbooks, having presented at so many places. But the truth is, she as a gynecologist has special interest in male fertility, which is very important today because 50% of the fertility caused in a patient coming to us is because of the male. We have Dr. Ashok Kumar, of course. We've saved the best for the last. Dr. Ashok is from Chennai, and he's a consultant fertility specialist and andrologist with a gynae laparoscopic surgeon. He's been trained phenomenally at a lot of places, has special interest and great interest in laparoscopic surgery and andrology. So, having introduced the whole panel to you, I think let's move on to the panel. We have divided it into two portions. The first portion is important questions which all of you want to know about. It's going to be questions which the panel is going to answer. And in case the first panelist, anybody else wants to add, the second panelist could come in. And after that, we have 10 cases. And these 10 cases are real case scenarios. And each case is going to be discussed. And after this, we would be having about half an hour of question answer with you, where any questions which you have would be answered by the esteemed panel. So the first basic question which all of us want to know is, what is the fundamental difference in the sperm assessment as per WHO 5th edition, and what are the new cutoffs? And who could be answering it better than Dr. Sudesh Kamath?
Thank you, sir, the opening batsman. Yeah, so presently what we are referring to is the WHO 5th manual, the 5th edition, 2010. That is like a Bible for us. Previous to this, the 4th edition was in 1999. There are so many differences. I'll come to concentration, motility, morphology. But if you go to the previous edition, the 4th edition, you will find there is about semen analysis, it is covered well in detail. There is a small description about the quality control. And just one page in the appendix, you will find in the, you will find on semen preparation methods. Since 1999, there have been so many newer methods which have come in, which have not been included in this 1999 WHO manual. All these have been incorporated, such as, like when you do a TISA, PISA. Suppose like in 2009, I wanted to refer to a
Dr.
manual.
Sudesh,
What is
I'm
the
sorry,
method I
Dr.
do?
Sudesh, I'm sorry to interrupt. Could we just know what is
Yeah.
the present concentration, motility and morphology?
Yeah, presently what we have concentration, the count should be more than 15 million per ml, and the total count in the ejaculate should be around 39 million per ml. Motility now is 40% total motility, out of which 32% should be type A motility, the active progressive. Morphology is the one which has changed up. Or today normal morphology equal to or more than 4% is considered normal.
Dr. Sudesh, can I ask you a small question? That
Yeah, sure.
now, since the morphology is about 4%, earlier the morphology was very different. It was about 30%
Correct.
in 1992,
Right.
and it was about 14% in 1999. So now, why is it so that the morphology has come down? Is it because of a different screening procedure now, or what is the difference? Why is it so?
Now, as per 2010, the whole way in which they have done the thing. Let's see. Am I audible?
Your
Hello?
audio is not too good. It should be a bit louder if possible, please.
Yeah, just. Yeah, what we have now is the lower reference values. As per, can you hear me? Yeah, am I
Actually,
audible?
yeah, Dr. Sudesh is audible. I think we understand that since the Kruger's criteria is being used, it's a different criteria of seeing the morphology totally. That is why it is
Correct.
4% now, which was
Yeah,
not
correct.
earlier. So earlier, what they used to see as 14% has now boiled down to 4% because of a stricter criteria. Not that morphology does not matter today. I think this is what
Correct, sir.
exactly you were wanting to tell us.
Right, sir.
Now, can you also tell us what is the understanding of the percentile value?
Actually, here, if you define it as percentile, it means like suppose you have a population of 100. You see the range, the low as an individual, you have to compare one individual with other individuals in the same group. And you have to see like 5%, what is the range of the count, motility, and what all. The lowest range of these, like what we have in the WHO, these all are fertile patients. So that is why we are taking that lowest percentile, 5 percentile. Even these people with low values are able to father children. So 5% is what we now normally take as the lowest minimum value.
So Dr. Sudesh, thank you very much for making everybody understand that in the whole spectrum which was seen, the 5th percentile has been considered not as normal, but taken as the criteria of the cutoff.
Correct.
So 5th percentile is the percentile which we have over here in this slide. I'd like to ask a question from Dr. Marlon from Philippines. Dr. Marlon, what is the limitation of the WHO 2010 criteria, please?
Yes, sir. So semen analysis is considered as the cornerstone for the initial evaluation of fertile men. But the physician should exercise extreme caution when interpreting the results because of its pitfalls, controversies, and limitations. This routine test cannot totally discriminate fertile from infertile men, except when man has a azoospermia, necrospermia, or globozoospermia. In fact, about 30 to 40% of men with normal semen parameters remain to be infertile. In addition, this routine tool cannot assess specialized sperm functions like the immature chromatin, DNA fragmentation, and reactive oxygen species. It also cannot assess the process of capacitation of the spermatozoa in the female reproductive tract and in the ability to fertilize the egg. So result of semen analysis is highly affected by the biological intra-individual variability. Besides, techniques among different laboratory centers are still poorly standardized. That is why it's important that this test should be carried out in a dedicated andrology laboratory. So overall, main infertility evaluation must go far beyond a simple semen analysis. It should be complemented with a good history taking, good physical exam.
Dr. Marlon, if I may just interject over here, what exactly is being wondered is this WHO 2010 criteria adequate, or what is the problem in this semen analysis criteria which we have at the moment?
The problem with the WHO criteria is that the semen samples are extracted from like 7 countries, and most of them are from the northern hemispheres. In fact, only 10% of the population is included. This is in Australia. So basically, some are underrepresented, and what included in the studies are overrepresented.
Fantastic. So the representation of India in our continent is not there. And the other thing is that Kruger's criteria, which is used as a strict criteria, has not been actually trained. People have not been trained for it. And because of the reason, people are not able to go ahead and use this particular criteria. And another thing is that the fertility of the women has not been taken into consideration in this whole, I would say, exercise. Now, there's some very beautiful things which terminologies which come over, which are always wondered and asked about. And you have the terminologies like aspermia. I would like to ask Dr. Sulba, what is aspermia?
Aspermia is a condition where there is complete lack of semen production with ejaculation. So there is no semen sample collected at all. This could be associated with conditions like ejaculatory duct obstruction or retrograde ejaculation, but this is distinctly different from azoospermia, where a semen sample is collected but no sperms are seen in it.
Fantastic. Now all of us can understand the difference between aspermia and azoospermia. Thank you, Dr. Sulba. Now, there are two things which come to us which are known as cryptozoospermia, and the other thing which comes to us is necrospermia. Now, what is the difference between cryptozoospermia and necrospermia? May I ask Dr. Ashok?
Yeah, hi, sir.
Hi.
See, cryptozoospermia is something like a virtual azoospermia, I can say, where on normal semen analysis, you find there are no sperms, but when you try to centrifuge the sample, you find occasional few sperms present in the centrifuge sample. So they're basically hidden. And most of the times this happens because there might be a small foci of production of sperms with very less sperms. So you cannot see them in the normal ejaculation, and when you centrifuge, you see them. Necrospermia is when predominantly the samples have dead sperms. Sometimes it might be complete where all of them are dead sperms. Sometimes it might be incomplete where you have most of them are dead sperms. But in necrospermia, I think what is more important for us is to differentiate whether they are dead sperms or they are alive but immotile. Because when you see a normal semen analysis, both don't move. And practically, what is more important is they're dead sperms. You may not be able to use it even in ICSI. If they are live and immotile, at least you have a chance of using them because we have a live DNA inside. So I think cryptozoospermia and necrospermia.
Fantastic. I think that is a very important criteria for all of us to understand that every sample which is azoospermic should be centrifuged to see if there are any sperms in the centrifuge. And the second thing is that all immotile sperms necessarily may not be dead. Thank you, Dr. Ashok.
Thank you, sir.
Now, when to evaluate the male partner and what are the components of evaluation of the male partner? Now, most of these patients come to gynecologists. And in your clinic, there is something which always happens. You always wonder how to manage these patients. So I would like to ask Dr. Ekika Singh, because she as a gynecologist gets a lot of patients, that when to evaluate the male partner and what are the components of evaluation. Dr. Ekika. Dr. Ekika, is she with us?
Yes,
Dr.
sir, she's with us. She'll have to unmute.
Just a sec.
I have done for that. I've done it for you, ma'am.
You are unmuted.
Yeah,
Please.
okay. Okay, can you hear me now, sir?
Yes.
Yes. Okay. So evaluation of male partner should be along with the female partner, and we should think of evaluating a couple, an infertile couple, even like after 1 year of unprotected coitus, and they desire to have a child and they are not able to conceive, and there are no gross anomaly which can be seen or found in both the couple, then we should be evaluating them. But age also is very important. If the age is more than 35 of female, or maybe the age is more of male, then we can consider evaluating them even at earlier interval, maybe at 6 months of time. And the component of male evaluation factor, it would start with the history. We should take a proper history in which fertility history, the sexual history, medical history, surgical history, occupation history, all should be thoroughly asked for from the male. A good examination, physical examination, and then basic blood analysis. At my center for that basic blood analysis, I go for probably a blood group, a complete blood count, viral markers, and a semen analysis. And depending upon the semen analysis, later on, we can go for the other investigations. So this is the basic component.
Correct. So very nice. Dr. Ekika has actually summed it beautifully, that after 1 year, if the age is more before that, and examination and history are very important. These needs to be done. Please understand one small thing. If you personally cannot examine the patient, have somebody to examine. It could be a physician, it could be anybody, a surgeon, to examine the patient. Please do not send the patient for ultrasound, because ultrasound is not a substitute to examination. Now, when and how will you evaluate the endocrinal status of the male? Dr. RahulReddy.
Yes. Sir, good morning, sir. Generally, I divide hormonal evaluation into two categories. Am I audible, sir?
Yes,
Yes.
very well, very well.
So if patient is affordable for Indian scenario, you can do complete hormonal panel like FSH, LH, prolactin, testosterone, thyroid. And if patient is obese, then always obese or alcoholic, then we have to do estradiol along with these hormones. But basic what recommendations says is FSH, testosterone, and thyroid. If testosterone is on the lower side, these two will give us some diagnosis. If testosterone is too low, then we have to find out why it is too low. Then we have to do LH, prolactin, and estradiol at a secondary level if patient is not affordable. But as per guidelines, it is FSH, testosterone, and thyroid.
Correct. Fantastic. In fact, there was another question which I wanted to ask you is that, well, the criteria has been beautifully said that testosterone and FSH and thyroid as well could be added if the sperm is less than 10 million. And if there is impaired sexual function or any other endocrinopathy, then we need to definitely investigate these patients. When would you recommend a scrotal ultrasound on this patient? Dr. Martins.
Yeah. So although scrotal ultrasound is relatively non-invasive, safe, and inexpensive, scrotal ultrasound is not routinely done for the evaluation of infertile men. Just what Dr. Sunil had mentioned earlier, careful and meticulous physical examination can identify most of the scrotal pathologies, like the varicocele, spermatoceles, epididymal induration, or testicular masses. However, scrotal ultrasound can provide information in the assessment of clinically challenging cases, those that are located in the upper scrotum, those with a previous history of scrotal surgeries. So overall, scrotal ultrasound is used in those patients in whom physical examination of the scrotum is difficult, and if you are suspecting a testicular mass. It's not indicated in all patients with varicoceles, and it is not routinely done to differentiate the type of azoospermia, although it can be helpful in determining testicular volume or testicular size.
Fantastic. Fantastic. Dr. Marlon,
Yes,
do you do your own ultrasounds or do you have somebody else doing ultrasounds for you?
Somebody's doing ultrasound for me. We have the radiologist. I'm not doing the ultrasound by myself.
Ultrasounds. So it's very interesting. It's very interesting that a lot of people believe that the ultrasound of the scrotum is a very important investigation. But like Dr. Marlon said, it does not substitute the examination. So it's very important for all of us to take this as a take-home message at the moment. In fact, in case all of you are sitting on the computer, I would love to see you type IGT. I got that. That would be great. In fact, this is one message which should go ahead. But there is something interesting, that a transrectal ultrasound is something which gives us a lot of information. And a transrectal ultrasound is done by the same probe with which the transvaginal sonography is done. So there is no extra cost in terms of the machine as it would be considered. I would like to ask Dr. Ashok, when would you recommend a transrectal ultrasound in a patient?
Yeah. So a transrectal ultrasound, mainly, you are looking at the vas, seminal vesicle, the ejaculatory tract, So basically, you're looking at the outflow tract. So if you're suspecting any obstructive azoospermia, that is, clinically you find that, the patient has got good volume of testes, he has got a palpable vas, and but still on semen analysis, you find that the volume is very less, the sperm count is low, or it can be complete azoospermia, then probably, and you've done a hormone analysis and shows most of them are normal hormone analysis like FSH normal, testosterone normal, then I think you are suspecting some sort of obstruction. Then you can use this transrectal ultrasound. And most of the times, the cutoff is the seminal vesicle gland. If the anterior posterior diameter is more than 1.5 centimeter, that means it is dilated. So it says that there is an ejaculatory duct obstruction or a seminal vesicle atresia. So it's mainly to rule out a complete or an incomplete obstructive azoospermia. And another important thing is, if it is obstructive, most of the times, we can treat it surgically. They may not need an IVF for ICSI. So it's indicated only in obstructive azoospermia.
So beautiful, fantastically explained, Dr. Ashok. In case the semen volume is low and the vas is palpable, you need to get it done. So now, how many of the people who are with us do an IUI? Please type in ID, I do, ID, I do. I would really come to know how many people of us do an IUI. Fantastic, ID, fantastic. I have it running, yes. Dr. Ritu, Dr. Raja, Dr. Sagar, Dr. Vivo, Dr. Megha, Dr. Sulva, Dr. Radhna. We have so many people who do an IUI. Dr. Nina, Dr. Sunita, Dr. Manju, Dr. PC. And I have people raising their hands as well. But what I would love is people typing. My goodness, I realize and we realize that about 50 to 60% of people who at the moment are with us do an IUI. Now, all of you would like to know that once a semen analysis has been done, what is the criteria for the IUI? And I would like to ask this from who else but Dr. Sudesh Kamath of what are the determinants of a good IUI sample and what should be the pre and post process parameters for a successful IUI. I'm sure you would love it and you would really like to know about it. Let me ask Dr. Sudesh Kamath about it. Dr. Sudesh.
As far as IUI is concerned, all of you know the success rate is actually very low. It is hardly 8 to 10%. So basically you have to select the sperm sample. If the count is below 5 million, then I would advise don't go in for IUI. You can offer the patient better options like ICSI. The total motile sperm count has to be above 5 million. Morphology is very important. Most of the studies have shown if the total motile count is say around 5 million or morphology is less than 4, the pregnancy is almost zero. There is hardly any pregnancy. And this other thing what you have shown, 10 to 20 million, 5 to 10 million, these are the different ranges. 5 to 10 million is what I will advise everyone.
Fantastic.
As far as pre and post wash is concerned, most important is the post wash sample. How you prepare it, you have to concentrate the sperm. The volume what you inject should not be more than 0.3. You should have at least 10 million good motile sperm in the final sample, the media, what you'll be injecting inside.
Okay, Dr. Sudesh, I'd like to ask you a question. In case the sperm count is low, not less than 5 million, but still a low sperm count, what is the method of semen preparation which you would use?
Basically, the method which gives you better sperm with less DNA fragmentation is density gradient. We have two different methods, but density gradient is one which is preferred, especially for low sperm counts or if the samples are infected or there are lots of debris. So density gradient, double density gradient is the method.
Fantastic, fantastic answer. In fact, I'm sure all of you must have understood that IUI does not have too great a success rate, though it has a reasonable success rate where the low sperm count is fine. But with the low sperm count, if it is less than 5 million, there is no point of doing an IUI. And in case the insemination count, the total motile count in the inseminate, which is going to be about 300 microliter, If it is more than 1 million, you could try. Less than 1 million, there is no point. A fantastic question at the moment, because this is very important. And the importance of this is, what is the role of DFI? Dr. Rahul, what is the role
Yes.
of DFI?
Sir, I think this is most debatable question in male infertility now. Whether to do DFI in the beginning or not, because there are so many papers which are suggesting importance of DNA fragmentation test. But when we consider Indian scenario, where a DFI cost is around 5 to 8,000 rupees, and it adds the budget. So now problem is, now not many labs are doing standardized DNA fragmentation test. But it is mandatory. See, there are certain cases it is must. Sometimes you may end up in legal issues if you're not doing DFI. If you are taking the couple for ICSI. See, like couples with recurrent pregnancy loss, advanced male age, and patients with varicocele. When we see a patient with grade 3 varicocele, but his semen parameters normal, when we are taking him for ICSI procedure, if there is poor embryo growth, then it becomes a legal issue. Because if we are not doing, the patient is going to some other fertility center. If they do DFI, then it becomes an issue. So all of us, all the doctors has to understand, and it always we have to discuss with the patient. And my suggestion is, DFI gives us very good diagnostic value, but instead of doing a DNA fragmentation test, because most of the labs where we are sending DFI, they are not standardized. So we have to look for factors which increases DNA fragmentation. That is very easy.
Very nice, fantastic. But now, evidence-based, if we ask today, what are the indications for which you would like to do a DFI in patients?
Okay. One, when there is advanced male age, or patient who had previous chemotherapy or radiotherapy for some malignancy, and third one, recurrent pregnancy loss.
Fantastic.
And patients.
Yes, please continue.
So, and patients, as I said, with varicocele, to operate varicocele or not, we can, if all other semen parameters are normal, we can decide based on the DFI value.
Great.
And
great.
Poor embryo growth.
Fantastic.
Poor embryo growth.
Dr. Marlon, would you like to add something to it?
Yeah, because I'm a urologist, so I'm also with the comment of Dr. Rahul. If we have normal semen parameters, with if a patient has a significant varicoceles and normal semen parameters, you can request for a STF testing, and if it turn out to be elevated, there's some basis that it can back up you doing a varicocelectomy for patient with normal semen parameters. But again, these are still controversial, but we're going to that.
All right. So, Dr. Sudesh, now, if you have a patient who has a high DFI and the patient has come to ICSI, what is it that you particularly are going to keep in mind and look at it with the fashion? Go ahead.
Basically, we have two options. One is now, see, when suppose we have, say, DFI of 50% or higher, when you do a ICSI, there is no way to identify which sperm is DFI positive. You may end up, or even if say it is 20%, you may end up picking up those sperm and injecting. So the only option is we have now special sperm selection methods like IMSI, where you magnify the sperm say 6,600 times. You look for the vacuoles and pick up sperms which are free of vacuoles, which are supposed to be free of DNA fragmentation. The second option, and then one more we have, is the mix technique, where we can get a good, we separate all the apoptotic cells which are supposed to be high in DNA fragmentation. We separate them. We get a solution free of DNA sperms, fragmented sperm. Second option is then do a TISA. Because the testicular sperm, you have seen the DNA fragmentation is quite low. And that most of the results have shown that using testicular sperm is a much better option.
Okay. So we have all this about DFI. So we have understood that a DFI would be done if there is recurrent pregnancy loss, if there is previous ART failure. Now it has been seen that in patients who have an IVF failure, repeated IVF failures, get pregnant by ICSI. and the chances of ICSI in a high DFI are good. So ICSI is actually the answer. I would like to,
Like if you don't, can I add just one point, sir?
yes, please. Now, let me complete just a minute. I'll just complete this. So something for us to understand is why does ICSI have a better result than IVF over if there is a high DFI? And that primarily is because we need to understand that the oocyte has a repair mechanism once the sperm has gone in. And the DNA which goes inside the oocyte, that repairing can possibly be done in ICSI, which would never be done in IVF. So just like Dr. Sudesh had said, we need to understand in high DNA fragmentation, the results of IUI and IVF are poor, but those of ICSI are better. Yes, Dr. Ashok.
No, just two things I wanted to add. If you're doing an ICSI, probably the embryologist will be happy if we give, repetitive samples. Means, don't keep an abstinence typically that what we say 2 or 3 days. Probably they can ejaculate one in the morning, and after 2 hours, if he again ejaculates another sample, and the second sample has got less DFI compared to the first sample. And also, I think give the sample as close as to the ICSI, because the more time you keep your sample in the lab, probably you're doing in oocyte travel at 10 o'clock, and if he gives a sample in the morning 7 o'clock, then you're keeping it for more than 6 hours, 7 hours. So I think the shorter duration you keep the sperm outside, and the second sample would be little beneficial when you're thinking in high DFI, sir.
Fantastic, fantastic. So it has to be short abstinence, quick sample, quick delivery, and quick ICSI. This is something for us to understand. Now, there's a very interesting question which is there, and I would like to ask it from Dr. Ekika. Is daily sexual activity during mid-cycle necessary, considering the sperm longevity?
Sir, as you said just now, you said shorter abstinence is good. As now studies have come, we have seen that. But in my clinical practice, the couple or the male partner generally thinks if they have abstinence of more than 10 days or maybe 15 days,
No.
they will have a very good semen parameter.
Dr. Ekika, my question is different. My question is, a lot of men get tired having daily intercourse during the fertile period. Is it necessary or not?
Sir, actually during the mid-cycle period, when the fertile periods are there, it can be like not daily and alternate day. Yes, it increases pregnancy chances, and better like if there is a much ejaculation, the better sperm might be there. So yes, it is helpful in sperm longevity. So probably.
Okay, Dr. Sulba.
Yes, sir.
Yeah, what is your idea about this?
So, what happens unfortunately is that there is such tremendous pressure on the couple to perform during the fertile period that we come across a lot of people where it is now leading to marital discord, expectations are different, and a lot of times the husband is not able to perform at the fertile time. So we always try and tell them, don't make it like a schedule that it must be 36 hours or every 48 hours or alternate day. This date to this date is your fertile period. Within this time, if you feel like it every day is fine, twice a day is fine. Within this time, if you feel like it once in 3 days is fine. Because we know that the cervix acts as a reservoir, and after natural relations, the sperms will remain active in the female genital tract for even 3 to 4 days. So it should not become like a compulsion that they have to do it every day or alternate day.
So this is a very important point which all of us need to know, that telling the patients to have intercourse every day from the 12th to the 18th day can create a lot of pressure. And therefore it is necessary for us to understand. And we have this answer. Now, I think we would like to go on to the second part of our program, which is the case discussions. Would the participants want to take part in this program? In case you want to, and if you're interested, please type in BIO. BIO is bring it on. Bring it on, BIO. I would like a lot of typings of yours. Yes, in case, because these are the questions which all of you would like answered in every case. And we have we have actually taken true case scenarios across the spectrum. So I would love to have and see how many people of us want to take part in this, because we would also like you to be on the chat. If there's any question, you put on the chat, and we would like to answer all your questions at the end of it. BIO, Yoganand is saying BIO, Payal, Dr. Vimlesh, Dr. Raja, Dr. Preeti, Dr. PC, Dr. Galaxy, all the people over here, I can see, my goodness, BIO. So yes, we consider and we go on with the first case. And our first case is a 28-year-old couple married for the last 4 years with a history of subfertility, unremarkable medical history, no prior pregnancy. For the female factor, nothing significant in history, physical examination or HSG. Both tubes are patent. Now the semen analysis was done and the concentration came as 12 million, motility was 30%, and the morphology was 4% by WHO criteria, and the volume was 3 cc. Now, Dr. Sulba,
Yes.
what are you going to do?
So if you look at the semen parameters, and we do now know that the total motile sperm count gives us a lot more information regarding the outcome than going just by the individual criteria. This is a sample which has a 3 cc volume, which is good enough. And the total number of sperms in this ejaculate would be 36 million. If 30% of them are motile, that's about 1/3. So 12 million motile.
One minute. Dr. Sulba, a simple question for the audience. What is
Yes.
the next thing you're going to do?
Sir, I will counsel them for IUI.
One second. Are you going to get a repeat semen analysis?
Yes, sir. Yes, sir. I assumed it was done on more than one occasion.
No, it's the first semen analysis we've got done. So the
Okay,
most
yes.
important thing for us at this moment is any patient who comes to you with a semen analysis, a low count, get it repeated after at least a 3-day abstinence as the second. So this would be the first thing. Anything else, Dr. Sulba, which you would like to do with this? You would like to physically examine and take the history of the patient.
Yes, sir.
So we would do this thing. Now, we have physically examined, we've taken the history of this patient, and we've got the second test done. And the second test, now this is what we find. On examination, we have a large left-sided varicocele, which we have examined and seen. The volume is 3 cc. The concentration this time turned out to be 30 million sperms per ml. The morphology is 4%, but the motility is 20% motility present. Now, in a condition like this, if it is there, what is the next thing which you would like to do, Dr. Marlon?
Since this is a young couple, this 28-year-old patient with varicocele and an abnormal semen parameters with a low motility, I'll be advising this patient to undergo varicocelectomy.
Okay. Before the patient undergoes varicocelectomy, Dr. RahulReddy, is
Yes.
there anything else which you would like to do?
Sir, the option, since the female, there is no female factor, we can always try with medical management. We have to discuss with the couple, asking whether they want a single child or one child or 2 kids. If they are planning for second pregnancy, then it's better to operate, because instead of waiting for this varicocele to damage the testis. If they say, doctor, we are happy with one child, we can put them on antioxidants, and we can wait for a couple of months, and later we can give them option of IUI versus varicocele surgery.
Now, there's a question I would like to ask you. If there is a patient who comes to us with oligospermia, what would be the and you have a patient like this.
Yes.
You are going in for medical treatment. The patient says, I don't want surgery.
Yeah.
Now, you are going in for a medical management. What would be the medical management which you would like to do?
So medical management, 2 things. See, one, since his first semen analysis was 12 millions, definitely I would like to do hormones, FSH and testosterone.
Okay.
Because varicocele, most of the varicocele patients, they end up with low testosterone. If there is low testosterone, then it's worth giving a HCG trial, and along with antioxidants.
Okay.
Antioxidants, Even if patient is affordable, then we can put them on a concoction of coenzyme Q10 and astaxanthin. Not affordable, simple vitamin E and vitamin C should be.
Fine. So you have done a testosterone of this patient, which ideally you would not normally do till it is about 10 million. But otherwise, since he is varicocele, the woman is okay. You want to do a testosterone, you've done a testosterone. It has come as low normal. Is there any other option apart from HCG which you can give to this patient?
No, so if FSH is on the lower side, then it's worth trying clomiphene citrate. But if FSH is on the higher side, it's better to directly start HCG instead of starting with clomiphene citrate.
So, okay. Now, Dr. Ashok, would you like to add something to this?
Yes, sir. I would not directly start them on HCG. Probably, yes, testosterone gets reduced. So you see for a testosterone is a estradiol ratio. And then if they are less than 10, probably I am more comfortable using anastrozole or aromatase inhibitors, which...
No. At the moment, this patient does not have any obesity. This patient has, okay. Now,
even instead of using HCG injections...
Could you get an estradiol done if he is not obese?
No, most of the times it's in obese, but it need not
if it
be
is not obese, will you get an estrogen done?
Yeah, I can get it done. I can get it done because it is the ratio which matters.
No. It's a question which I'm asking you, which is very pertinent, and the audience needs to carry it with them. If you have a patient who has a low testosterone, right? Yes. I mean, but not a very low testosterone, and the patient is not obese, and he has a varicocele as well. This patient, I'm talking of this patient, he is not obese. Will you get an estrogen done?
I will definitely get it done.
What is in which patients do you get estrogen done?
No, because why I'm telling...
Or do you get it done routinely in every patient?
No, see, now in obesity patients, it is history, the aromatase activity is very high. But we also need to know whether the ratio is altered or the ratio is not altered. The ratio can be altered even in testicular failure because they'll be having a normal. The normal thin male will have a normal estradiol, but they'll have a low testosterone.
So let us come back to this patient. So in this patient, we have planned a medical treatment. And in the medical treatment which we planned is, the most important thing for us to plan for this patient would be antioxidants in medical treatment. Because this patient has a varicocele. First, we've got a testosterone done and we have decided that, well, for the medical treatment, we would put him onto clomiphene citrate or with antioxidants, or we would put him onto HCG. In case he is obese, we have got an E2 done, and in case the E2 is high, just like Dr. Ashok said, we would put him on anastrozole. So this would probably be, in a nutshell, the medical treatment. But something else which I would like to ask you is, Dr. Marlon, what would be the indication for a varicocelectomy?
So there are a lot of indications for doing varicocelectomy. First, if there's an abnormal semen parameters, there's a known infertility. So those are the indications for varicocelectomy. Aside those with hypogonadal symptoms, those with intractable pain secondary to varicoceles, those are indication. But for this patient, I think doing a microsurgical varicose surgery for the surgical ligation versus medical treatment will be beneficial for this patient, because medical treatment compared to surgery, the surgical correction, the surgical correction has a better outcome than the medical treatment.
Dr. Rahul, can you let me know one thing, that what would be the good prognosis patients for a varicocele surgery and what would be the bad prognosis patients for a varicocele surgery?
It all depends with the testicular size and FSH. If FSH is on the higher side, that means already there is enough testicular damage, patient may not improve. If FSH is on the lower side, these are the ideal patients who will improve. Okay. But definitely in this scenario, sir, in this case scenario, he will improve with the varicocele surgery.
See, just like you got the testosterone done in a patient whom, just like what you're saying exactly, if the testosterone is down, if there is testicular hypertrophy, if the varicocele is not grade 3, grade
Yes.
1 or subclinical. And if there is, in these cases, Y chromosome microdeletion, then in any case, we would understand that the prognosis would be poor. But otherwise, the prognosis is good. So how many of us in this patient, in case we find that he is good prognostic, would we do a varicocelectomy? Dr. Ashok, would you do a varicocelectomy?
I didn't get your question, sir.
The question is, in a patient like this, would you do a varicocelectomy? The history you have, this patient.
Okay, in this patient, yes, definitely yes, because the female factor is normal. They don't have any other proved indications for infertility. And I think doing a varicocele, there will be a great improvement.
Great.
And I would do it.
Dr. Marlon,
But
would you do a varicocelectomy?
I would just add 2 points, practical points on varicocelectomy. What I've seen, most of them, how it has changed from fertility wise. I think Malam also will agree, because when we worked with Dr. Mark Goldstein in Weill Cornell, see, doing micro varicocelectomy, I think we have to also ligate the cremasteric veins, that is extratesticular veins, and he even used to do the gubernaculum veins. And that's how we proved that the recurrence rate was less than 0 to 1%, just not ligating the testicular, the spermatic veins. And another important point, what we saw and what we started practicing, even I do now, is using Doppler peroperatively. We all think it is only one testicular artery which is coming, but sometimes we might have two testicular arteries. And when you use the Doppler, and I've seen in patients where I find two testicular arteries, and when I spare both the arteries, they respond very well. They come with normal counts compared to the patients who have one. So I think these two practical tips are very important.
Great. So we have understood that if the varicocele needs to be operated, it has to be done microsurgically. It does not have to be a laparoscopic or a routine surgery. This is one thing which we understand. Dr. Sulba, I'd like to ask you something.
Yes, sir.
What would you like to do in this patient, an IUI or a varicocelectomy?
Sir, I will counsel them for a varicocelectomy initially because they do meet all 4 criteria where a varicocelectomy is indicated. That is, it is a clinical varicocele, not just seen on radiology. There is documented infertility. The female factor is normal, and there is an abnormal semen parameter as well. Now, in case, as you were mentioning, he's not willing for a surgery, we can plan an IUI with the current parameters, but I would also like to counsel them to freeze a few semen samples in that case, because as the varicocele enlarges, the semen parameters can further deteriorate and some men can even end up as spermic.
Dr. Sulba, I'll be a devil's advocate here. And the patient's parameters you have seen over here, the concentration is 30 million. The morphology is 4%, motility is 20%. And in this patient, the DNA fragmentation you've got done, it is okay. Is fine. Would you prefer doing an IUI? Would you prefer doing a varicocele surgery? If the patient gets pregnant in IUI, then it may happen that the surgery may not be done.
Yes, sir.
So
both the options can be in such scenarios, sir, where there is a dilemma between 2 decisions. It's always better to counsel the patient in detail about both, give them the costs involved, give them the success rates involved, and then take a joint decision along with the couple.
So why I ask this question is, in a patient like this, varicocelectomy, just like Dr. Ashok, Dr. Marlon, Dr. RahulReddy, Dr. Sulba said, is the surgery which is indicated. However, you also have to question and ask the patient if he is ready for surgery, because it is not necessary that after the varicocele surgery, immediately or even after 3 months, you may get phenomenal results. So you have to let the patient earn the surgery. And in case during this time in a patient like this, he asks for an IUI, you can go ahead with an IUI after counseling this patient for a varicocelectomy. Now, there are 2 questions which are important and which need to be answered. In case there is an adolescent who's come with pain and a large varicocele, and fertility is not the answer, will you operate or will you not operate? Yes or no fast? Dr. Rahul?
So pain, definitely yes.
Dr. Marlon?
Yes.
Dr. Ashok?
So varicocele with decreased testicular volume, then yes. Or abnormal semen analysis, yes.
No. One sec. Semen analysis is fine. It's a young boy. He has a large varicocele. He's an adolescent and he has pain.
Yeah, pain, yes.
Yes, this was the, so the question is one. Number two, in case there's decreased testosterone level and there's a large varicocele, yes. Now another question, if there is varicocele with non-obstructive azoospermia, who all out of you would operate?
At the first go, I would not operate, but if there are no sperms available on testicular sperm aspiration, then probably yes, I would try.
Dr. Rahul?
Sir, it's based on histopathology, sir. Definitely, TISA first, later varicocele surgery. Even in TISA, only 2 scenarios will improve with varicocele surgery, sir.
Great. So,
late maturation arrest and hypospermatogenesis.
Correct. So now we have discussed varicocele, and I'm sure oligospermia and varicocele have been covered quite well in our particular case scenario, which is a true case scenario. Now this is the second case. The second case is an azoospermic 33-year-old healthy male with 31-year-old healthy wife, azoospermic, 4 cc testes. The FSH is 25.2, LH is 5.1, testosterone is 244, prolactin is 8.5, estradiol is less than 20. What would you do? Dr. Sulba?
Sir, I would like to get also the karyotype done because this does look like.
No. What would be the next thing you would do? Dr. Rahul?
Yes. So here, it's a known case of testicular failure. So my approach, there are 2 schools, sir. One, you can directly do TISA, but my way is put them on hormonal therapy, that means HCG injections and antioxidants for 2 months. Then if there are some sperms, we can freeze and send them for IVF. If there are no sperms in spite of hormonal management, then we have to take them for TISA or micro-TISA.
Okay, now I'd like to ask you a question. The first thing which every person in the panel would like to know is, how would you diagnose something? First of all, let me ask you one question. Is this non-obstructive azoospermia or obstructive azoospermia?
Non-obstructive.
Dr. Rahul?
Non-obstructive.
Okay, Dr. Sulba?
Non-obstructive.
Okay, so all of us are clear, non-obstructive and obstructive azoospermia. What are the 3 things which you would see based on which in a minute you would say this is obstructive or non-obstructive? Dr. Marlan?
So first, it will start in the clinic of physical, good history and physical examination. In the physical examination, small testes will point out to a non-obstructive azoospermia, and elevated gonadotropins like the FSH will point out to a non-obstructive azoospermia.
Okay, so you have diagnosed between obstructive and non-obstructive. Dr. Ashok, if within 3 sentences you could make the differentiation between the 2.
Yeah, how to differentiate between non-obstructive and obstructive. That's what exactly now Marlam has said, that, the testicular volume, usually the testicular volume is between 15 to 20 cc. So anything less than 8 cc, it is less. So that goes in favor of non-obstructive, obstructive, normal testicular volume. The FSH levels, usually anything more than 8 to 12, 8 to 12 is taken as high FSH. So that goes more in favor of non-obstructive. Anything less than 8 goes in favor of obstructive. And look for the VAS. And if you can feel the VAS with all these symptoms low, then it is non-obstructive. If there is absence of VAS with normal testes, then it goes off obstructive azoospermia.
So we have differentiated now between the non-obstructive and obstructive azoospermia. And we are clear about this patient, because I'm talking about this patient. We're clear about this patient, that this patient is a patient of non-obstructive azoospermia. Now, one thing which I would now like to ask you is, in this patient, what would be, in a nutshell, in non-obstructive azoospermia, what would be your plan, Dr. Rahul?
Sir, if patient is affordable, we have to take them for genetic testing, Y chromosome microdeletions, and karyotyping. And if Y chromosome microdeletion is normal, that means there are no deletions, then it's worth trying a hormonal management. I don't jump and do testicular biopsy or TISA in these patients. I will give a try, and after 6 to 8 weeks, then I will take them for a TISA or micro-TISA.
Okay. Now, the second question is, which I would like to ask you is, you have done the hormonal management, you have done the genetic testing, and you are clear at the moment that in this patient, there is no Y chromosome microdeletion.
Yes.
Now, how are you going to counsel your patient, Dr. Marlon?
So since this is cases of non-obstructive azoospermia, I will advise this patient to have a sperm retrieval and follow-up by IVF or XC. And provided that the testosterone level is normal, so I'll proceed with sperm retrieval, like a microdissection testicular sperm extraction.
Dr. Ekika, are you there? Dr. Ekika? Dr. Ekika? Dr. Ekika? Dr. Sulba?
You will have to unmute yourself, ma'am.
Okay.
Ekika ma'am, unmute yourself.
Yeah, actually, there was some internet problem at my side, so probably it was muted.
Now, Dr. Ekika, were you there with us with this case?
Yes, sir. I mean, I joined just 5 minutes because there was some internet problem,
No problem.
so I was removed.
I'll just ask Dr. Sulba because the case is going on. Dr. Sulba,
Okay.
Yes, sir.
how will you counsel the gynecologist? As a gynecologist, the woman, what will you talk to the woman?
So we have to again consider the different options. Of course, surgical sperm retrieval is one option, but in our country especially, there is a lot of financial stress involved as well. So we do also have to counsel them about what is the prognosis, what percentage chances of sperm retrieval can be expected in such cases, and would they rather opt for donor sperms instead?
Now, there are two things. There are two things into this. Now we have to understand. I asked you specifically this question because it was very important. We need to understand one small thing, that we as human beings today should not all of us should actually go on to third party only after we have told everything about these people being able to use their own gametes, which means it's not only the sperms, it's also the ova. For the people and the couple who come to us, they normally would like to have their own gametes. So they have to be given all the options of their own gametes, and only if they opt in, just like Dr. Sulba said, because of financial constraint, for anything else, this should be offered to them. So this becomes very important. Now, Dr. Ashok.
Yes, sir.
Yeah. Now, in a patient like this of non-obstructive azoospermia, is PISA an option? I'll just ask you, just yes or no?
If I have to just say yes or no, I would say yes, yes.
No. I'll tell you why. Because it would answer the people's question. Would you do PISA in non-obstructive azoospermia?
I would not do, sir.
Yes. No. Would you do TISA in non-obstructive azoospermia?
Yeah.
I would do a diagnostic TISA.
Okay.
Yes.
Would you do a TISA in non-obstructive azoospermia?
Definitely
Yes.
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 Micro TISA
Yes,
to
sir.
be more specific.
Would you do a micro TISA in non-obstructive azoospermia?
Yes. Yes.
Now, this is a question like Dr. Ashok has said and answered perfectly. A PISA is only for obstructive azoospermia, not for non-obstructive azoospermia. Dr. Rahul?
Yes, sir.
I'd like to ask you one question now. In which patient would you prefer a TISA, and in which patients would you prefer a micro TISA?
Sir, it all depends on the patient's option. Now, generally what I do is, in this scenario, since it is a small testis, I will counsel him for all procedures at a time. TISA, TISA and micro TISA. If patient is willing, because most of the times we do this in a fertility center, and we have a very good embryologist who can look for the sperms. So what I do is I counsel them for all the three procedures. So in TISA, if sperms are there, it's okay. We stop at TISA. Otherwise, then we can go for a micro TISA. But there is another school which says if it is it is not hypospermatogenesis or late maturation arrest. If it is clear a case of Sertoli-cell only syndrome, doing a straightforward micro TCA may not give us a second option. We don't have a second option in this scenario. After in second micro TCA, results of sperm retrieval is very poor. It all depends how comfortable is my embryologist in freezing sperms.
Dr. Ashok, what is your plan in this patient?
No, see, I would not go directly. See, once I know it's a non-obstructive azoospermia, I always do a trial TISA. This is what I do in day-to-day practice. I do a trial needle TISA and I map it. So that, if I get a sperm, I just map it. This is the place. There are certain points, upper pole, middle pole, and lower pole, and lateral. And I tell them, you have got these sperms. We are very happy. If you don't get these sperms, and I do a histopathological examination, and then depending upon the histopathological examination, I say that, you will have to go with microtisa with oocyte retrieval. And depending upon the histopathological examination, I say what are the chances. Like, for example, hypospermatogenesis and maturation arrest, I say it's more than 70%. Probably only Sertoli-cell syndrome, I say only probably 15 to 20%. But I'll go simultaneously with the oocyte retrieval. If I don't get a sperms, then you have to give me an option of either freezing the oocytes or going ahead with a donor insemination. So this is how I go it, sir.
Okay. Dr. Marlon, what do you do?
For all my patients with non-obstructive azoospermia, I usually offer micro dissection testicular sperm extraction. I offer this because I know it's higher sperm retrieval rate, it's higher pregnancy rate, and live birth rate. Other sperm retrieval technique like the other open techniques or percutaneous techniques, they can be an option as well, but they offer a little or less outcome compared to the outcome of microtest. So for this patient, I'll offer microtest.
So now we have a fair idea of what needs to be done in this patient. This is our second case and we have 8 cases more. So I said the discussion on these cases actually will take time. And yes, if it is a non-obstructive azoospermia, just like Dr. Rahul, Dr. Marlon and Dr. Ashok said, the PISA is out. TISA, if you do a multiple biopsy, multiple puncture TISA and you get sperms, great. You have spared the patient of a TISA or a micro TISA. But ultimately, in a lot of patients, micro TISA is needed in these patients of non-obstructive azoospermia. So now,
sir, and one more thing, I usually what I do when I do a micro TCA, especially in people whom I think there are no chance of getting sperms, I do it the day before evening if the oocyte retrieval is next day morning, because I give sufficient time for the embryologist to check. And also I've seen sometimes when I incubate it overnight, morning I sometimes see sperms which was not seen on the before.
Agreed. You always do a micro TISA before the pickup.
Yeah, don't do it on the same time.
Yes, this is the standard. This is the standard procedure of doing micro TISA below. And just like you say, incubation of these sperms at times gives motility to them, and you get better sperms after incubation. Now the next case is a patient, 26-year-old male, and I think we'll go a bit faster because the rest of the cases are very interesting too. We'll go faster. 26-year-old male of subfertility is found to have azoospermia 2 semen samples, 4 cc, FSH high, testosterone normal. You've got a biopsy done. Now the patient normally comes with a biopsy. I just want to ask you over here the next question. In the testicular biopsy, if the patient comes to a biopsy, what biopsy results give us what chances of retrieval? Dr. Rahul.
So maturation arrest, late maturation arrest and hypospermatogenesis, these 2 scenarios give us better sperm retrieval rate.
So which means if a patient has...
It's around 40%. 40% sperm retrieval with these 2 scenarios.
So now if you have a patient who has come with a biopsy, so that biopsy is not a waste because you have an idea that you can prognosticate the patient based on this biopsy report. I'll go to the case 3. Next case. Now there is a 33-year-old man with an unremarkable past history, low libido, primary infertility, slight gynecomastia, firm testes 3 ml in volume, semen analysis is azoospermia. I would like to ask the audience, please. Is the audience with me? Yes. Can you diagnose? Please put it into the chat box. What do you feel this patient is? In the chat box. In the chat box. 33-year-old
Sir, your
with
slide is not seen.
Yes, the
one
slide is not seen. You've got
You're
to change the
33.
slide,
Yeah,
sir.
you have to change the slide.
Sir, because it's the case 3 with 26-year-old male,
no, can you see
which
the
has been
case
projected.
4? Can you see the case 4?
No, sir.
No, sir.
we
No,
can't
sir.
see.
Nobody. We can't see, sir.
One sec.
We cannot see your image also, sir.
One sec. Can you see a change of the slide?
No,
No,
sir,
not yet, sir. Not yet.
Just a minute. Just a minute. Can you see it now?
No, sir.
No, sir. Still stuck on 3.
Dr. Amit? Dr. Amit?
Yes, sir. Do you want me to share the slides?
No, you share the slides from this. But what you do is, my picture also is not coming while I'm,
Yeah,
I
you're
don't
not
know.
seen.
What's the issue? I just don't understand, because over here, but you can hear my voice.
I can
Yes,
hear
sir.
your voice, everybody.
Yes, sir. We can hear your voice.
Sir, can you just check your camera is like by mistake if it's clicked?
No, one sec, no.
The slide should still change.
Now can you see my,
We can see you, sir, but the slide has not changed yet.
okay, now I'll just share, I'll just do the share, I'll just share the screen again.
Yeah, we are
With
able
some
to
issue.
see that message.
I'll just share the screen again. Can you see it now?
No,
No, sir.
You can't see it.
no.
No, sir.
Am I still the administrator?
Of course you are, sir.
You can see my face. Okay, can you share the 4th case, please?
Your
I'm
video is
I'll do
also
that.
still, sir. You are still.
Something with the internet connection, sir.
It's
I
hung,
think
sir. Your video is hung.
your internet is slow or something. We need
One
to-
sec, just a minute. Can you?
Should I share?
Yes, please share. क्या हो गया problem? One sec, I'll just check if.
So
The
this is
narrative.
slide number case 4, case 3, test biopsy, case 3.
क्या हुआ था? क्या? Speed is okay. Speed is fine. हाँ? उसको डालो. फोन लगा. फोन लगा. फोन लगा.
Can you see the screen, sir? Case 4.
No, I can't see it.
Can rest of the panelists see screen 4?
No.
Case
No,
4.
no.
No,
it's
Dr.
still
Amit, we
case
cannot
3.
see.
I have shared the slide.
Yes, sir. We can.
You can. It's still case
No, we
3
cannot.
that I can see.
Yes,
Yeah.
Dr. Silva, I can see the case 4 now.
You
No,
can
we-
see. I cannot see it here.
I cannot see.
I can't see it.
One sec. I'll just put it on to another. The problem that is happening is the upload speed of the internet has gone. I've just checked it. The upload 5G. वो कहाँ है फोन का हॉटस्पॉट? Note 5 है? Can you see me now?
Yes, sir.
Yes, sir.
Now you
Yes,
can see
sir.
me fine? Okay.
We can see
Yes,
it.
sir. Yes.
Yes. Now I'll do one thing. I'll just share the screen. I've hooked it onto the other net which I have. I'll
Okay.
just share the screen. It's fine.
A backup.
Now you can see 4.
No, it says
No,
that
no,
you have
sir.
started screen sharing. Yes, sir. Now we can see it.
Good.
Yes, perfect.
I lucky have 2 Wi-Fi connections. One is Airtel, one is Jio. Airtel has gone and Jio is on.
Two wife or Wi-Fi, sir.
2 Wi-Fi. my friend, there are people in South India who are lucky to have 2. We in North India survive and prosper with 1.
I think 2 Wi-Fi is better than 2 Wi-Fi anyway.
And anyway, what you can have, you should have. So now, great. So now we are there with this case. I would like the audience to join us in at this moment. We've had a little bit of problem in the theater where the anesthetist has not been able to get the drug and now the patient is under anesthesia. So we have the case 4. Case 4 is slight gynecomastia 33-year-old male, low libido, firm testes 3 ml in volume, and is azoospermic. I would like, what is the answer? What is normally what you would feel the patient is having? Can you please put it into the chat box? What do you think it could be? Wow, we have an amazing audience, and the amazing audience is spot on. So the amazing audience has diagnosed the patient as Klinefelter. Great. So the audience has got it right, Klinefelter. Now in a patient of Klinefelter, Dr. Sulba, what do you think you would like to do?
So even in a patient of Klinefelter's, it is possible to retrieve sperms by surgical sperm retrieval techniques. So a lot of times, in fact, it could even just be a case of Klinefelter mosaic. And those are the cases where the likelihood of sperm retrieval are higher.
Now, the first important thing is you would like to do a hormonal profile of this patient. You would like to diagnose it. You would also like to know that the karyotyping of this patient would be needed. So in this patient, because I'd like to go a bit faster, because we'd also like questions from the audience. Testosterone is low, FSH is high, LH is about high, the karyotyping, so it's confirmed it's Klinefelter. Now, once it's confirmed it's Klinefelter, Dr. Ashok, what would you like to do?
So these are the people, they definitely need a medical management before you go with a sperm retrieval. You should try to bring the testosterone to as normal as possible, because these people have very low testosterone. So I would definitely pump them with HCG, and also they have abnormal testosterone estradiol ratio. Though I additionally put them on letrozole. I bring the testosterone to normal, and then only I plan for testicular sperm aspiration.
Great. So it's a great answer that you would normally put them normal for testosterone to go ahead and do a TSA with microdissection. And this is the answer for that. Dr. Rahul, what is the prognosis in these patients in whom of Klinefelter for a microdissection and the ICSI which you do?
Yeah. Sir, my sperm retrieval rates are around 20 to 30% in these patients. And before that, previously I used to counsel them. Now I send them to a geneticist for proper genetic counseling.
Okay.
At least to avoid legal complications, I always send these couples to a geneticist, let them get genetic counseling and come back to me for microdissection.
Now, how many patients have you had till now, Dr. Rahul?
11.
11. Now, in these 11, did you find any difference in the pregnancy rates of Klinefelter vis-a-vis hypospermatogenesis?
No, pregnancy rate, because I didn't follow it because this was done in various fertility centers. Only 3 of the patients I had sperms because I didn't follow up with pregnancy rates.
Okay. If you followed up the pregnancies, what is the difference in the chances of these patients having a genetic defect? These babies having a genetic defect?
So there is 50% chance. That is why I don't take this risk. Always I refer these patients for proper genetic counseling.
Dr. Sudesh, in the laboratory, what is the difference? Have you found any difference in the kind of samples which you get in Klinefelter versus other testicular, I would say, problems?
No, as far as sperm is concerned, no difference. If I find sperm, then they are all the same.
See, why I asked this question particularly was that something for us to understand is that the embryologist and a good embryologist looks for these sperms. The gynecologist has the most important role. Dr. Sulba, Dr. Itika, you have the most important role of actually counseling the patient in terms of the future genetic defect.
Future genetics.
Yes, sir.
So if you have a genetic counselor, you're lucky.
Yes, sir.
Take a minute, 1 second. Pause of this lecture. Can you see the next slide, please? Hello?
Sir, is it the case? Sir, yes. Is it the case, or sir, is it about the percentage?
Case 5, azoospermia.
No, sir, we can't see.
No, sir, we can't see that.
Just pause. One second. Can you see it now?
Yes, sir.
Yes, sir.
So we have the fifth case. It's a patient who has no VAS. No VAS. Now, in a patient like this who has no VAS, what would be your diagnosis? Dr. Sulba, what will be your diagnosis?
So per se, because also of the semen parameters, it looks like a case of congenital bilateral absence of vas difference.
Okay. Now, Dr. Ekika, what is the investigation you'd like to get done?
Sir, probably in this case, again, we will go for hormone analysis of the patient
So we would also
to see.
counsel them for a CFTR gene mutation test.
Yes, CFTR gene.
So the
sequencing
CFTR
also.
gene you would get done in whom? The male or the female?
Female.
But we can't assume that all men with CBAVD have CFTR gene mutation.
This is a very important question.
Yeah.
Whom would you get the CFTR gene done in? And Dr. Rahul Reddy has said the female. Is us पर में आदमी को टेस्ट औरत में करा रहे हैं ऐसा क्यों मैडम?
So in both it should be done.
In both.
If they are affordable, get first in male and then in female.
And then in females.
Otherwise, as Rahul Reddy sir said, if female and female is positive or negative, then depends.
See, the most important is the female because it's a recessive problem. And in case it is there in the female, it comes and you know it's recessive, it becomes very pertinent. So it probably needs to be done in both. Now again,
so the percentage in female, I would like to know. I mean, how much? What are the chances? 2%, 4%, and on that basis,
the CFTR CFTR as it is very low in our country, very low in our country. So because it is so low in our country, the chances are minuscule. But still, you need to get it done because if it is positive and you have examined and you quite sure the patient has CFTR and you get it done, then of course his sperm cannot be used. Very simple. Now we have this patient who is the sixth patient. Azoospermia vasectomy has been done, and there's a normal testes. FSH LH testosterone is normal. Now, in this patient who has had a vasectomy done, what would be the approach of Dr. Rahul in this patient?
Sir, considering the age of the couple, you would always counsel them for ART procedures. Unless they are not affordable for ART procedure, most of the times I counsel. If they are not willing for ART, then I will take them for vasectomy reversal.
Dr. Marlon?
Yes. For this case, since the wife is already 35, so more than 35 years old, you have a chance of doing vasectomy reversal. The pregnancy rate will be down in the pregnancy rate. So for this case, I would advise for them to undergo ART.
Dr. Ashok?
Yes, sir. I would also advise for ART. Not only the age, even the duration is more than 7 years. It's more the duration between the surgery and reconstruction, the lesser the chances of reanostomosis.
Okay. Now, Dr. Rahul Reddy, if this patient were a young patient and this patient had a lesser duration and the wife was 28 years old, what would you have considered reconstructive surgery?
Definitely. Definitely,
Now,
but I will give them the option. I will discuss about the success rates, and I will tell them the possible options, and they have to decide.
Okay.
So can I just add that even if the wife's age is 28, we can't decide just based on age that vasectomy reversal would be a better option for them. We have to first check her ovarian reserve because we very commonly in our country come across women with diminished ovarian reserve even in their late 20s.
Great. So what the conclusion is that, see, in a young patient where the wife is young, she has no problem, the reversal is a good option because if in case you get sperms, it's a permanent thing that the man can have after another child. It is less expensive. However, in case the age and the time of duration is high, you would go ahead for an ART procedure. Now, this is the seventh question, and the seventh question is, please understand it's very important. Partner with 32-year-old has been trying to achieve pregnancy for 5 years. They have described a normal sexual and harmonious life. The semen analysis was normal and the couple had already attempted 5 IUI inseminations with no success. There was no indication that obtaining a sperm sample was difficult during this period. The partner opted for IVF in their case of idiopathic infertility. 2 days before the oocyte retrieval, the couple contacted the IVF unit concerned that the sperm could not be obtained as he has been unable to attain an erection for the last 1 week. So the patient is on stimulation. You have not had a chance to freeze the semen, and they have come to you and told you that, well, there is no erection. What will you do? Dr. Sulba.
So this seems more like a case of situational ejaculatory dysfunction, since he has been able to do that in the past. So one thing that helps is psychological counseling. And if that doesn't help, then there are various modalities that can be tried. For example, giving them sildenafil 50 milligram 1 hour prior to the attempted intercourse or the attempted masturbation. And other modalities that can be used are, the slow penile vibration with the vibrator. And if that doesn't work as well, taking the wife's help, using erotica doesn't work, then there are other more advanced techniques like electroejaculation and TISA.
Electroejaculation is not the best procedure for these people, but yes, you counsel, you use a vibrator, all those things are fine. Dr. RahulReddy, would you like to answer anything about this? Because I think the maximum number of experience of erectile dysfunction in Telangana is with Dr. RahulReddy. Yes, please.
No, whatever doctor said is correct, sir. I think we have to counsel them. Most of the patients, it is like situational and ejaculation. We have to counsel them, put them on a vibrator. If we can even ask them to collect sample from home. But there are some legal implications in this. So it's better to put them on vibrators. If in spite of using vibrator, if he is not able to give sample, then we have always a TISA option on the day of IVF.
Dr. Marlan,
yes, sir.
All these things have failed and the egg retrieval is due. What will you do?
I'll do sperm retrieval.
By which method?
Simple as a TISA.
As a TISA.
Great. Yes, sir.
Great. So our panel, Dr. Ashok, anything to add?
No. I think most of them.
Beautiful. Dr.
Only one point to add.
Sir,
TISA is contraindicated in this.
Sir, sometimes.
Yes, Dr. Ekita, please.
Yeah, sometimes these patients, when they have this problem, as Dr. Sulba said, that psychological counseling and then sildenafil can be given, many times they want to be with their partner. So we have to make sure that, after probably it's on the day oocyte retrieval is due, then even after oocyte retrieval, sometimes we really have to tell them, okay, we can arrange for a place, they can be with their partner and they feel more comfortable to ejaculate. So that's a psychological way of getting it done.
Great.
That is also another reason why we in fact ask them on the day of pickup to collect the sample before the wife is anesthetized. Because they get even more stressed out once she's in the OT and then she's not even available to help him if it's required.
Great. So they're fantastic inputs you've got. Fantastic.
Sir, one point to add.
Yes, please.
Sir, TISA is contraindicated in these patients.
Yes.
We're not supposed to do TISA. We're supposed to do only TISA in these patients.
Absolutely. Absolutely. That is the reason I asked Dr. Marlan.
I can just add something. Yes, sir.
Yes. Dr. Sudesh, yes.
I think oocyte retrievation also is an excellent option. What we follow.
Yeah, but
the patient is not able to produce a sample on the day of home pickup, and suppose he is not willing for TISA, we have a very big oocyte retrievation program. So later on, whenever he has no problem, he comes, gives a sample, he can go ahead and inject. That is what we follow.
Correct.
And so one thing more I would like to add, if with this patient, even if we can freeze the sample also, if we can get it after giving all the counseling and he's able to give up to the sample, that should be freezed.
No, it
Because
was not.
probably.
Yes, I agree. But in this patient had reported even before that erection is not taking place for 7 days.
Yeah. Okay.
So
Yeah.
this patient was
That's a
particularly.
different case.
So now these are all case scenarios which are the way they are. Now, ejaculatory dysfunction. This is one patient who came to me, and this was a 31-year-old man, and he came with his new wife, aged 21, who was very young, very smart, and they entered my clinic and stated that the husband has never been able to last more than 5 minutes during intercourse. She appeared extremely anxious and slightly angry, and she wanted me to fix this problem. When I asked the man said that he does not see any problem with his ejaculation and has only come because of his wife. Now, in a condition like this, Dr. Rahul.
Yes.
Dr. Rahul, what is your plan? What do you think? What would you tell this patient?
So, difficult situation, because now it's like a marital conflict. Because what we have to understand the male, we have to understand the female, and we are not supposed to take sides in these scenarios. We have to satisfy both.
I agree, but you need to over here tell them very clearly that normally intercourse is 2 to 8 minutes.
Yes.
And if the man is 5 minutes, it's fine. The world is not the way you think it is. The world is different from what it is. One. Now, supposing this man had a lower threshold and you felt that it was premature ejaculation, what would you have done in this patient?
So, premature ejaculation, he said, again, if first thing is we have to rule out it is anxiety related premature ejaculation, or because since the wife is forcing, it can always be anxiety related premature ejaculation, and we have to rule out other causes of premature ejaculation. Sometimes even erectile dysfunction at a later date secondarily can produce premature ejaculation. So now we have to differentiate whether it is sexual dysfunction or only ejaculatory dysfunction. So now we have to put him on medical management. Generally, I don't believe in counseling, squeezing technique. Generally, I start them on SSRIs. My favorite SSRIs in these kind of patients is fluoxetine. I start with low dose fluoxetine, then next level is paroxetine, then depoxetine.
Okay, so normally when you give them, you start them with fluoxetine, go on to paroxetine, and then you put in them on depoxetine. Okay, fine. Do you normally also add sildenafil to it?
No, sir. Nowadays I started adding low dose tadalafil along with daily doses of tadalafil with daily doses of SSRIs.
Fantastic. So
we do get a combination of dopoxetine and tadalafil, Hapol tablet, where both the things are taken in one tablet only, sir, for premature ejaculation.
But for daily usage, if 10 milligrams of tadalafil and 30 milligrams of depoxetine will give severe side effects.
Yes.
For occasional use, it's okay.
Actually, that combination has something faulty in it,
Yes.
which is the dosage. Just like you get omeprazole with domperidone, where one tablet needs to be given once a day, and the other tablet has to be given 3 times a day, and they make a combination out of that. So that is the problem with these two drugs. Now, next is...
Sir, and another thing is, when I was closely working with Dr. Ranjit Ramasamy in Miami University, I found when I had a discussion with him, he used to give tramadol tablet 1 hour before the sexual intercourse, and he has found very good results with even with tramadol.
Yes, perfect. Very good input over here. Yeah. Now,
sir, I just want to ask one thing. Any contraindication or any cases in which we should be thinking twice before giving sildenafil to these patients who have problem of erectile dysfunction or premature ejaculation? Anything which being a gynecologist should keep in mind about the male?
Dr. Rahul,
Yes, sir.
I
Dr.
think they're
Dr.
having.
Ekika wants to know in which patients not to give sildenafil.
Sir, sildenafil, see, if only in patients who want an erection on particular day, like for ovulation days,
No,
where
the question,
there is performance anxiety. that-
no. The question is different. What is the contraindication for sildenafil?
So sildenafil can cause ejaculatory dysfunction. High dose sildenafil can delay ejaculation.
Dr.
That
Ashok,
is the
Sir,
only
sir, I
cause
think,
contraindication.
sir, in patients
what
who
about
are
the
thinking with
cardiac patients?
cardiovascular disease,
Cardiovascular, yes. So
or
that's
and especially if they are on nitrates, they add an addictive
that's
effect and they
Okay.
go for a severe hypotension.
actually
So,
the question was this.
that's
So now one thing is for us to understand is that the percentage of people who actually have a contraindication to sildenafil is very less. However, because initially there were a few deaths because of sildenafil, it became as if it was a very dangerous drug. So it's not so dangerous a drug. This was the particular thing. Now, you know, it's a fantastic panel we have been there, which we need. So this is just a case of pyospermia. Dr. Sudesh, if there is, how would you distinguish between round cells? See, I'll just go in a nutshell. Whenever you get pus cells, it is not necessary they may be pus cells. They may be round cells as well. And by mistake, you may going into thinking this person has pyospermia. How would you distinguish between round cells and pus cells? Dr. Sudesh.
Basically, you will see, three different types of cells. One is the neutrophils, other are the macrophages, and third are the sperm precursor cells. So only even staining, regular staining is very, very difficult to differentiate between neutrophils and sometimes the spermatids, where there may be multiple lobe nuclei. Only way you can do is by peroxidase stain. There you and actually it's very simple. You take the semen sample, you take toluidine, just mix it. After half an hour, you just see wherever peroxidase neutrophils are, the granulocytes, they will be stained dark brown. So that's the only way you can differentiate. So many times the reports are wrong. So where you say it's pyospermia, it may just be the spermatids and the immature sperm precursor cells.
Dr. Ashok, what will be the treatment which you will give in case the patient has a high number of pus cells?
I would definitely treat them with antibiotics. I usually prefer doing a semen culture in sensitivity. If it can pick up the growth of any organism and specific antibiotics, then I give them. If they don't, then I usually put them on doxycycline. And usually you should at least give for 3 to 4 weeks. It's
4
not that
weeks.
regular 1 week to 10 days. Don't give that, because the concentration of the antibiotic attained in the seminal plasma is very less, and to act against those things. So 3 to 4 weeks of doxycycline, or if we can do a culture in sensitivity, it should be fine.
Dr. Marlon, what is the antibiotic which you would give?
We can give doxycycline, 100 milligrams twice a day for 3 weeks, or a second line treatment can be azithromycin, 500 milligrams, or sometimes if this does not work, you can do a trial of ibuprofen or anti-inflammatory for these cases.
Dr. Rahul, what antibiotic is your preferred choice?
So I start with doxycycline, but it depends on culture report, sir. Because if it is Enterococcus fecalis, doxycycline may not work. So I had to, ampicillin is the best choice of drug for Enterococcus fecalis.
Okay, and which patients would you use a quinolone?
Quinolones, either E. coli or Klebsiella. These three are the common bacteria seen in semen cultures. So generally, I start with semen cultures. If semen culture is positive based on the organism, I start antibiotics.
Okay, now the culture is not possible. A lot of times it is not possible with so many gynecologists. If they want to give a combination of 2 antibiotics, please understand, it's a very, very pertinent question. If they want to give 2 antibiotics, what would be your choice and for how long?
Doxycycline for 3 weeks.
If another antibiotic needs to be joined with it?
Azithromycin.
Azithromycin. Okay.
So previously, I used to give quinolones, but because of side effects, I stopped using them.
Okay. So we have a very fantastic answer on this. And the next is teratospermia. This is the last question, after which we would go ahead with all the question answers. And teratospermia, if there is teratospermia and the sperm count is high, the morphology is poor, what would be your criteria for IVF, ICSI, and IUI. I'd like the panel, Dr. Sulba.
Sir, if the woman is young and she has a good ovarian reserve, and if the count is high but only the morphology is poor, we could initially try with IUI as well. And there is some studies which have indicated a role of using antioxidants in such cases. But if the count is also low, or if the woman's age is higher or reserve is lower, then I would rather go for IVF or ICSI.
Dr. Ekika?
It's somehow the same. It has to be followed that way.
Dr. Ashok?
Yeah, exactly, sir. Isolated teratospermia might be like,
doesn't have.
I didn't get. Hello? Yeah, isolated teratospermia. I totally agree with Sulabh that, we can try with IUI initially. And if it is not getting conceived, then we go ahead with IVF, especially ICSI.
Dr. Marlon?
Yeah, with regards to the teratospermia, there's a good paper there by Dr. Ranjit Ramasamy on the even of less than 1%, there's no significant difference with regards to the outcome.
Fine. So we have this question answered as well. So we have tried to cover in this for the amazing panelists, by the amazing panelists, for the participants, a lot of questions in these cases, which are real case scenarios. I think it must have been an extremely educating program for us. Now, it's time that we come on to the question answers and the question answer session. My phone. And there are a lot of questions which are there, though I'm sure a lot of questions must already have been answered in the panel itself. So let me just check on with all the questions which have come. So the first question which I've got is from Dr. Sugandha. And Dr. Sugandha asks a question: if a male has a count less than 5 million, FSH, LH is borderline, testosterone is normal, what to do?
Again?
Dr. Ashok. If a male has a count less than 5 million, FSH, LH is borderline, testosterone is normal, what to do?
Yeah, again, that's what you evaluate the patient and see if there is any cause for the decreased sperm count. Like, you examine the patient, look for varicocele. And if I think when the management is concerned, you can still give a try with IUI. Antioxidants.
We fortunately have about, my goodness, we have fortunately about 30 questions, 32 questions. So I'm just trying to pull in the questions together to make a single question so that all could be answered. There is one question, there are about 4 questions which are similar. In case the semen count is less than 5 million, patient is not keen for IVF, can we pull in 2 to 3 samples and process for IUI? Dr. Sudesh.
You can freeze the samples.
No, but what? No. She's asking another question. She's asking the count is less. No. She's saying we pull in the samples. Will we be able to better the IUI results?
When you're collecting the samples also at the same time or at different times, and are you planning to freeze the samples and then pull them together and then inseminate?
The question is, does pooling of samples of counts less than 5 million?
You can always give it a try.
Okay. So the answer is that you can give it a trial. It's not necessary that pregnancy may happen, but you can try it. Now, one question which I've received by a lot of people is, I would like Dr. Marlon to answer it. Should DFI be done for all?
Sperm DNA fragmentation is not indicated in all infertile couples. So there are indication. First is for male patient with normal, with significant IUI failure, IVF failure, those with recurrent pregnancy loss, and those patients with life risk factors and a borderline semen parameters. I think those are the patients that get in all patients presenting with infertility.
Great. Now a question from Dr. Sulba, and the question is, how long do sperm survive in semen after IUI, for IUI, and how long do sperm survive in the vagina and in the female genital tract after natural intercourse?
Definitely they survive much longer after natural intercourse, because the cervical surface, the cervical mucosa has got crypts that act like a reservoir. And these sperms also undergo capacitation. And now when we do an IUI, first of all, the sperm wash takes care of the capacitation itself. Secondly, we have bypassed the barriers of the vaginal vagina directly into the uterine cavity. So their longevity there is a lot shorter. I would say about 12 to 24 hours.
So probably
the answer to this would be that you do an IUI as soon as the preparation is there, and it is best if you do an IUI within 30 minutes of the preparation. As far as survival is concerned, it is much longer for IUI. As far as they definitely survive for at least 72 hours if the sperm count is fine and there is no infection. But yes, they can even survive longer. That is the reason I asked the question, is intercourse needed every day. This was the reason for this. Now you have another question which is, which have come is, what is the relevance of anti-sperm antibodies in male infertility, Dr.
So probably as far as the studies and evidence says, and even in my practice, I don't take it in consideration because I do have IUI option with me. So generally, I don't do much of
Dr.
antibody tests.
Ashok,
Yes, sir.
where there is a bilateral varicocele grade 3, do you operate both sides or only one side? If so, when
Sir,
and
if
why?
it is a grade 3 varicocele on both the sides, yes, I will operate on both the sides. There is no doubt in it. Because, varicocele, we know that, it causes testicular atrophy, it causes decreased sperm count. There is no sense, like, operating on one side and leaving on the other side because it's going to progressive. In fact, now there are many articles coming, if there is grade 3 on one side and grade 1 on the other side, should we operate? Even in those scenarios, we might, after 6 months, it can become grade 2 or grade 3 and you need to undergo another surgery. So if it is bilateral varicocele, I will operate on the same setting, both the sides.
There's a question answered. Dr. RahulReddy, please answer it. Varicocele grade 2, should they be operated with marginal semen
No, if it is bilateral, it's worth operating, sir. If it is unilateral grade 2, we can always wait.
Then there's, in oligospermia, what is the role of giving testosterone? Dr. Marlan.
Actually, testosterone is contraindicated in the treatment of infertile men. So it should be out of the treatment options. So for this patient, testosterone is a no-no. It's a big mistake. It's contraindicated.
What is the role of vasography? Dr. Ashok.
Yeah, vasography, we don't do it only if you're thinking of obstructive azoospermia and you're planning a surgery for the patients. Then also preoperatively, I'm not doing it now, only peroperatively to see whether both proximal and distal tubes, distal vas is good. Then we do it peroperatively, but not preoperatively.
Dr. Sudesh, question for you. How good are the results of oocyte cryopreservation?
We get excellent results. I would say 90% and above in our center. We are very, very happy.
Dr. Rahul,
yes.
In case you need to give a patient is not giving a sample, you need to give a drug to this patient for the sample. What drug will you give and how would you give the drug and what instructions?
Sildenafil citrate 50 milligrams. 50 milligrams. Generally, I use film form, sir, because it is easy to absorb. Action comes in 15 to 20 minutes. Otherwise, absorbable, oral absorbable sildenafil citrate 50 milligrams. After, if not possible, then we'll put them on a vibrator.
Another question is, because there are 3 questions together,
yes.
Which is the condition in which you give HCG and HMG or FSH to the patient, and in what dosage?
HMG in only 2 scenarios, sir. One, if there is testosterone injection induced suppression, then we have to put them on HMG, or else hypogonadotropic hypogonadism. This is the patients with only testosterone deficiency and high FSH. HCG is
Dr.
enough.
Ashok, yes, rational use of antioxidant and outcome in patients.
In what patients, sir? Outcome of?
Antioxidants, rational use and outcome in patients.
See, antioxidants is because now any semen parameters are getting damaged. It's mainly because of ROAs. Now it's been shown that the reactive oxygen species is high, the oxidative stress is high.
How long would you give them, and what is your choice?
I would at least give them for 6 months, 3 to 6 months, the minimum I would give, and I give a combination of vitamin C, vitamin E, folic acid, apart from the regular CoQ10 and astaxanthin.
Okay. Now there is a question which I'd like Dr. Marlan to answer. Which test should we get done for DFI? SCSA, Comet, Halosperm, or Tunnel?
With regards to the different testing of SDF, there's still no the best test for SDF. You can do tunnel. It depends on the andrology laboratory. You can do tunnel. You can do SBF. Which test is the best to detect SDF?
Now, there is a beautiful question, which there's so many questions, my God. And I'd like, they're interesting questions. The answers need to be crisp. The question is, in this period of lockdown, many couples have got pregnant, even the older ones. Doesn't that suggest that increased coital frequency increases chances of conception?
It is not just a question of increased coital frequency. They are also sitting at home with not much else to do. Many of them are not working or they're working from home. That also leads to reduced stress levels. So that could also be improving their marital relations, and yes, increased coital frequency as well. So I think all these factors put together can lead to a better pregnancy rate.
Also, there are evidences which says, in a week, twice or thrice, if twice or thrice intercourse, it does lead to an increased pregnancy outcome. So, and obviously when everything else is not there, the stress is out, the work stress, the office stress, and everything is out.
The other question is, there's a young male, 28 years old, history of mumps in childhood, azoospermic, low testosterone, low FSH, testicular biopsy shows 2 to 3 dead sperms, few Sertoli cell present. What to do?
These are the patients who are ideal to go ahead with micro-TC, provided you give them with HCG increase the testosterone and then plan for micro-TC.
Dr. Marlon, how much is medical management effective in non-obstructive azoospermia?
For non-obstructive azoospermia, if there's an evidence of hypogonadism, meaning low testosterone, I think doing a medical treatment or medical manipulation is manipulation. If you repeat the semen analysis, there can be presence of sperm in the ejaculate. So that can somehow save you from doing sperm retrieval. But again, if there's no sperm on the semen analysis after hormone manipulation, you will
we are
proceed with
about more than
micro-test.
2 hours into the program. And let me tell you one thing, the participants who joined in, they increased and they have stayed on, which means 2 things. Number 1, we have a fantastic audience which really wants to learn. And number 2, I have a fantastic group of panelists who keeping them engaged. This is something fantastic. I would like to ask my audience, there are a lot of questions with me. Should we continue or not? In case you feel we should continue, just type in why. Just type in fantastic, fantastic, fantastic. Oh my goodness, this is lovely. You know, I tell you one thing. गाने वाले को तब गाने में मजा आता है जब सामने वाली महफिल सजी हुई हो और बोलने वाले को तब मजा आता है when we have a fantastic audience like that. Let me tell you one thing on scene. Same over here. It is you guys who are creating this for our panelists that they really are coming up with the best. I'm telling you, I love you all. Just love you all. So at this moment, I'm continuing with the questions. I'm just continuing with the questions, and the questions are very interesting. I mean, they're brilliant questions. I have received a question, which is, I have done an IUI of a patient 5 times. The patient has not got pregnant with a 10 million count. I counsel the patient now for IVF, but the patient feels that after 5 cycles, I will get the IVF done from somebody else. Should I have done the IUI for? Believe me, it's an honest, true question. Dr. Ekika.
Sir, actually, as far as in my practice, yes, before going for an IUI, it is very much necessary to sit with the couple and counsel them about the percentage of success and the number which they should opt for, and then eat. So probably for 3 to 4 IUIs are good enough, good number enough, and then it entirely depends even on the duration of fertility and the age of the patient. So many factors come into the picture. And if my patient with 5 IUI failures with me thinks that IVF he should get done somewhere else, then probably counseling to make him realize that whatever I did was for their betterment, for the low cost. And since now you're not succeeding, then the next you should go on.
Now, there's a question from Dr. RahulReddy. Dr. RahulReddy, what is the reason that people want to ask you so many questions? I think it's your brown eyes, you know. Really, Dr. RahulReddy, if you see him, you can't see it over here. He has beautiful brown eyes. And I'm a man, I don't know what the women must be saying. So it's crazy. So what is the dose of HCG which I should give, which you have answered in the chat box, but still other people would like to know. The second question is, should the same dose be there for oligospermia and low testosterone? The third question is, the duration for which HCG should be given. And the fourth is, please let me know everything. How do you give HCG?
Sir, there are 2 ways of giving HCG. If patient compliance is good, you can give HCG 2000 international units weekly thrice intramuscular. But in my patients with poor. So now what I do is, this is what I discussed with Dr. Rupincha sir also. So now we started giving HCG 5000 international units weekly once, and we give for 4 weeks, depending on the testosterone, if they repeat testosterone and estradiol. So 4 weeks for optimal, moderately low testosterone levels, 4 injections, and then repeat testosterone. Based on the repeat testosterone estradiol ratio, then you have to, but what I have seen is most of the patients after either clomiphene citrate or HCG, it is must to check for estradiol ratio, testosterone to estradiol ratio after 1 month of height, then add letrozole 2.5 milligrams once a day, or anastrozole 1 milligram once a day, along with HCG injections to maintain the TE ratio.
So in a nutshell, HCG you would give to increase the testosterone. The dosage has been told to you by Dr. RahulReddy, but please understand that in a few cases who have subnormal testosterone with an FSH which is normal, even clomiphene can do the trick. So it is not the answer for everybody. Which Dr. Sulbha is going to answer.
Yes,
should we inject all the washed semen intrauterine, or should we deposit some near the cervix? Please guide about the right
I
approach.
usually inject all of it intrauterine.
It is to be injected intrauterine, because if you were to inject it below, why do it? There is another question which always is asked by oncologists. Whenever I do an IUI, most of it comes out.
Yes, sir. Common question.
What would be the answer, Dr. Ekika, for that?
So it's entirely depends on the volume which is being used basically, and then the IUI catheter. I mean, how it's being inserted, whether it has gone absolutely intracervical or not. Then also the semen sample comes out, and the volume which is loaded.
How much
0.2 to 0.3.
Okay. Now, if you have treated microlesions and you inject very gently, you don't hold the cervix, and you do not lead to a contraction of the uterus, then the chances are that it would not come out. So it's the technique. Number one. Two, also the anxiety level of these patients. The more relaxed the patient is, the better. So you first have to speak to the patient for 2 minutes. It should not happen that the patient is on the table. She's waiting for you for 15 minutes in that position. You quickly come and say, "Jaldi baito, abhi karti hu IUI." Just talk to the patient for 2 minutes. She'll be relaxed. It would be better. Yeah. There is a question is, with unilateral grade 4 varicocele, what will be the management?
Yeah, now again, that's what now, since he has a varicocele, but he's just 12 years old, we will not intervene immediately, but we have to always know that, this varicocele can affect his testicular volume, it can affect his semen parameters. So if his testicular volume is good, if his semen parameters are normal, just keep under follow-up every 1 to 2 years. If you find any signs that, the testicular volume is reducing or the semen parameters are abnormal, then in view of future fertility, I would advise follow-up every 1 to 2 years.
Now, there is one interesting question, Dr. Sudesh, you have to answer. And the question is, if the semen is of high viscosity, what do I do?
You keep it for quite some time. After half an hour, still doesn't liquefy. What you can do is you can take the semen in a syringe, in a 10 ml syringe, and try to, release it drop by drop. That is the way you can break the viscosity.
Great. Yeah, the answer is there.
Yeah. Pass it through a syringe.
Now
keep on doing it, but you have to be gentle.
You have spoken about the lab. Now, Dr. Marlon, can we know if there is a very high viscosity of the semen, what could be the medical treatment of these patients?
Yeah.
Yes.
So the reports we can give N-acetylcysteine, 100 milligrams for 3 months. So that's a medication that we can give for this patient with the high viscosity.
There is a question on which I would like to ask Dr. Ekika. I have a patient whose IUIs have failed. Please let me know if I can give any steroids. Dr. Ekika? Yes.
Steroids, leading to in relation, find any particular relation between these two things. Probably my judgment of doing an IUI will depend on the other thing.
Why I asked this question from you is that there is no role of steroids in IUI.
Yes, sir.
And people should know that steroids are not to be used unnecessarily in the male or the female at all. Now, there is a question. I have a 26-year-old patient, 1 year of infertility, bodybuilder, long duration of steroids and nandrolone acetate. What should he do? She has written, what should I do? So I think what she means is, what should he do? So, Dr. Rahul.
Sir, these patients, there are two types of patients I have seen, where some of the steroids, they block only testosterone receptor, but free testosterone will be on the lower side. And the other scenario, because of these steroids, there is suppression of the HPT axis. So these are the patients where we can start with clomiphene citrate, or we can start HCG injections first. Later we can add and looking for children.
Okay, great. There is one question which I have received over here I have a lot of patients of oligospermia. These patients have no infection in their semen. However, I do not know how to treat them. And the couple comes to me, what medicine should I give to these people who are the accompanying husbands? A gynecologist is asking this question.
Okay.
Please understand, it's a very, very common predicament of every gynecologist. She's treating a female, she's treating a lady, and the husband is coming with that. The husband's semen count they have got done is oligospermia. There is no infection. And she's saying, what medicine should I give to these men?
It is very simple, sir. Only there is 3-step evaluation. So one, do hormones. Along with the female patient, we have to do hormones, FSH and testosterone. If FSH is on the higher side, then the patient. But if FSH is on the lower side, then they have to add clomiphene citrate, and along with clomiphene citrate, they have to put them on antioxidants. For patients with low FSH, if patients FSH is on the higher side and testosterone is on the lower side, then HCG and antioxidants.
Fantastic. I still have a bunch of 15 questions, but we are closely running into about 2.5 to 3 hour slot. And you know something interesting? This is lunchtime. And people are not going for lunch. But you know something interesting is in front of the web. You can have the lunch over here in front of you. You can have coffee. You can have tea. And if you want to have, you can have beer too. Nobody's stopping. In any conference in the world, could you sit down with food plate in front of you and somebody speaking to you? Or let me be honest, a glass of wine with you and listening to a webinar. So it's fantastic. The world has changed. I would request all of you to just note down a number on which I would send you the proceedings in a PDF. The number is on the chat box. 1 sec. one sec. I have put in onto the chat box 94122045000. Just feed in this number, and on this send your contact from WhatsApp, the contact which you have on WhatsApp. I mean on WhatsApp, when you go, your name comes, it's a contact which you'll have to send. My staff would take it, put it into this, make a broadcast. Please put down this number, take down this number 94122045000. Just put it down. So Dr. Marlon, let me be honest with you. You are, you know, the beauty is, I won't have to say that thank you very much for coming all the way from Philippines. Now I could say is, love you, you have joined from Philippines. And I would normally ask you, what is the time gap?
2 hours
And I realized the
minutes.
time gap is only 2 hours. Did you have
It's
you've
okay.
not been able to have your lunch?
Thank you so much.
So, Dr. Marlon, I think we would end it over here. Though there are a lot of questions, but I sometimes feel that movie bhi picture bhi kabhi khatam hoti hai. Movie, because he looks just like us. So it's amazing. Dr. Sulba, thank you very much. Dr. Rahul, thank you very much. Dr. Marlon, thank you very much. Dr. Ekika, thank you so much. Dr. Sudesh, you have been fantastic. And we have Dr.
Dr. Amit.
I think it's time to say goodbye.
Dr. Amit, thank you very much. Dr.
Yeah.
Kedar, if you are there, let me tell you one thing. You are amazing, Dr. Kedar. Fantastic webinar is held. Dr. Kedar said something fantastic to me. He's a very old friend, brilliant guy, works unbelievably for the ISAR. Sometimes I feel he was born to be the secretary officer. And the beauty of this human being is, he tells me he has his own way of speaking, which is very soft and slow, because he wants the point to be every gynecologist should gain. It should not be any scientific jingo. It should be practical things which everybody could follow. And this is exactly what I thought I'm going to do. And this is exactly what my panelists have done. Fantastic. I've had a brilliant panel. These brilliant panelists who are there. So before we end, of course, there is a course. Their chief of the reproductive division, who is Mr. Rajiv, sings beautifully. He's a great man. And I think we would like him to have the vote of thanks over here. But before that, I have given the number, and the number is 94122045000. Just put it in. Don't send me your number and name. Send. I'm thankful to this audience, this great audience, for being there. You have been there for so long, and this is the reason we are here for so long. Thank you very much. Really appreciate
Thank you.
people.
Thank you very much.
And we
Thank
appreciate
you very
you,
much,
sir,
sir.
for
Thank you
conducting
for
it.
being a wonderful
Thank you very
moderator.
much, sir.
So we really enjoyed
Good
this.
Thank you very
moderator,
much.
sir.
Thank you very much.
So really, it had been a wonderful moderation,
It's
no
been
doubt, any
really a
flaw.
very great learning experience.
Thank you very much.
Thank you, Dr. Jindal. It's a lovely pleasure to have on the board. On behalf of MCure, I am heading the division of IVF. On behalf of MCure, I am Rajiv Agarwal. With bottom of heart, thanks Dr. Suli and all the panelists who have come to join this webinar. Very thank you, sir, for joining and making this webinar successful. Dr. Sunil Jindal, a lot of comments are coming. You are a lovable person, great speaker. So thank you very much, sir, for making this webinar so successful. And I like to thank my team also, Amardeep, Amit Borse, for making this webinar great, and all the doctors who joined and heard patiently. सर जाते जाते सर एक शेयर हो जाए तो इसका सही समापन होगा.
हाँ जी.
सुनील सर.
अब आप
एक शेयर हो जाए सर.
हेलो.
आपकी आवाज में एक शेयर हो जाए मैंने कहा.
अच्छा शेयर बोले. चलिए एक मैं ये सोच रहा हूँ आपको कौन सा शेर सुनाऊं. मतलब एक बात सच कहूँ, ये माहौल ऐसा होता है कि इसमें मोहब्बत के और मोहब्बत वाले शेर नहीं चलते. इसमें एक शेर ऐसा होना चाहिए जो मोटिवेशनल सा शेर हो, जो कभी कभी मैं महसूस करता हूँ. तो ये बहुत जरूरी है. और वैसे एक बात कहूँ आपको, कभी कभी मैं महसूस करता हूँ राजीव जी, आपका कमाल है जो इतना सुंदर ये वेबिनार हुआ. और उसका आपको रीजन बताऊं, जो
दिल से जो चीज निकलती है
वो बड़ी खूबसूरत होती है. ये एक सच्चाई है इस दुनिया की जो बिल्कुल सच है. एंड दिस इज द रीजन वी हैड टू हैव सच ब्यूटीफुल थिंग्स. तो इस लॉकडाउन पे एक बहुत सुंदर सी चीज आपको सुनाता हूँ जो कहते, कैन यू पुट द स्पॉटलाइट ऑन मी अमित.
Amit, you put a spotlight on sir.
हाँ, तो आपको कहूँ बड़ी सुंदर सी चीज है. जो कहते थे कि मरने तक की फुर्सत नहीं है, वो आज मरने के डर से फुर्सत में बैठे.
Amazing. That's one of the best ones I've heard.
आगे सुनिए कि घर गुजार सुने शहर, बस्ती बस्ती में कैद हर हस्ती हो गई, आज फिर जिंदगी महंगी और दौलत.
Oh my God, that's beautiful, sir. It's beautiful.
और देखिए आपको आज एक बात कहूंगा, आप सुनिएगा बड़े गौर से. बड़ी सुंदर चीज है कि किसी ने गुजर जाने के बाद में शहरों को बंद होते कई बार देखा होगा. किसी ने गुजर जाने के बाद शहरों को बंद होते कई बार देखा होगा, लेकिन कोई गुजरे नहीं. लेकिन कोई गुजरे नहीं, इसलिए शहरों को बंद होते पहली बार देखा है। तो बड़ा सुंदर हमारी जिंदगी है। थैंक यू वेरी मच एंड इट्स बीन लवली। थैंक यू एवरीबॉडी।